Ophthalmology and Medical Center. So thanks for inviting me today to talk about phakic lenses. So I think the first thing we should talk about is why does the phakic IOL matter? So by 2050, actually over 5 billion people are already expected to be myopic, and 1 billion of them will have high myopia. So which means millions of people will fall outside what's considered a safe range for corneal laser procedures. So in our refractive center, we actually see a lot of these patients already who are not good candidates for laser, and are better candidates for phakic lenses. So, just for the residents first. So, what's a phakic IOL? So there's a key distinction from your standard IOLs, which we see in cataract patients. So, in a standard IOL, it usually replaces the natural lenses. In phakic IOL, these lenses are added in front before, but now more popularly behind the iris. So this preserves the natural crystalline lens, and we don't take those out. So on the right here, you see the main device types of phakic lenses. Right now, we don't anymore use angle supported lenses, which you see here on the right, because it causes a lot of endothelial cell loss. No? So in Europe, they still use the iris claw, seen here. But more popularly today is the posterior chamber phakic lenses. So I'll discuss the different brands later. Um, so again, it begs the question on why they matter. So you can see the photo here. This is actually a post PRK patient already. So PRK is popularly used for those who have higher grades or higher myopia. But in this case, this is a 10 diopter correction. So he came to our clinic with a persistent epithelial defect, haze, and reduced vision. So this is already at the 3 months post-operatively. On the right, you see inferior steepening, and there's also posterior elevation. So these are signs of ectasia, right? So this patient is a post-LASIK ectasia and following an 8 diopter correction. So in these patients, those surgeries were indicated and there were no problems during the surgery. Uh, but even though you have a perfect surgery, sometimes the cornea is not cannot withstand that level of removal. So what did we learn from these cases? So it's because if you do a high ablation for your high myopia, your high grades, or if you take out a lot of these tissues, you can have corneal ectasia, you can have corneal haze, epithelial defects, and of course, this will lead to poor visual quality and very poor stability in these patients. So all of them were very unhappy, which you don't want in a refractive patient, right? Because you're correcting them and they didn't have any problems prior. So next. So all of you are familiar with the refractive laser seen on the left side. As you can see, you will see how the ICL stacks up against these alternatives. So I mentioned ICL and not phakic IOLs because the ICL is a bit more studied or well studied compared to its competitors, and that's the only reason I placed it there. Uh, so to be on the conservative side, I just placed studies which focus on high myopia. So with PRK, which is a go-to for high myopia, ICL has already been proven to be better in acuity, predictability, stability, as well with LASIK and SMILE. So all of them say the same thing. It's better in stability and optical quality, aside from safety. Another a bit popular option for high myopia right now that we see is refractive lens exchange, no, in high myopia. Just because they don't want to do laser, so they're usually offered a refractive lens exchange. But we have to remember that in these patients, they really carry twice as much risk for retinal detachment because they are highly myopic. And more importantly, it removes natural accommodation in these young patients. So there are already several studies saying that even if you replace this with a multifocal IOL, which they say replaces your near vision, it's still inferior to your natural accommodation. No? Um, so the phakic IOL really excels in, let's say, high myopia and borderline corneas. So in China, Korea, Japan, so in the latest mga users meeting, they have already actually expanded the use of phakic lenses to those with moderate myopia, meaning those with -3 diopter myopia and not just high myopia. And they have excellent results. So just going back on RLE, because we really see a lot of patients undergoing refractive lens exchange, I just want to emphasize that there are really a lot of studies already emphasizing the risk of retinal detachment in these patients. That's why we really shy away from RLE if we have another option, which is a phakic lens. No? Uh, because of the rise in RLE or refractive lens exchange, now that we have multifocals, a group in Europe headed by Dr. George Al, who's a prominent refractive surgeon, already presented guidelines on how or when we should do refractive lens exchange in high myopia. And because they see a lot of this patient, so they already concluded that it's ethical if we do it in patients who have an eggshell length of less than 26 and only if they're over 50. All right. So anything less than that or an eggshell length more than 26, really want to wait for, development of cataract. So that's when we say that our lens exchange is warranted. So just a bit of something to think about. So now that we talked about why it's important to have phakic lenses, we now talk about the ideal candidate, like who do we offer this to, no? So, of course, after refractive screening, we take note of their refraction. So if you are starting your ICL journey or phakic lenses journey, I would reserve this option to those who are not candidates for laser if you want to be conservative, just because you'll get most satisfaction in these patients. Uh, if you're a what they call this, practice refractive surgeon, or you really do ICLs already, we can start offering this to patients with moderate myopia, as seen in trends in other Asian countries near us. So we also offer this to poor laser surgery candidates. Like, for example, you have very bad dry eyes, you have irregular or thin corneas, and of course, we already offer this also to those with stable keratoconus, especially if they have regular astigmatism. And then age-wise, in contrast to laser, we offer this to the older population, maybe around 21. FDA-wise, it's 21, but to be honest, we wait for the eyes to be stable because we don't want to do anything, to implant a lens wherein the refraction is not yet stable. And then a very, very red line we do not cross would be the anterior chamber depth, or how big the eyes are or how deep it is. So we measure using barometry, pentacam, to see how deep the anterior chamber is. So if it's less than a 2.8 millimeter, we don't do any more ICL because it will cause us a lot of problems in the future. So I'll show you those later. Aside from those, a healthy endothelium is ideal, because if there's the lens or the endothelium would really be exposed to the lens, and if there's any touch, that would suffer greatly and would cause you problems with your cornea. So those are the main points that we really look out for when we consider these patients. So when you have your patient already, you have selected them, you already have the ideal candidate. The next question is what's available here in the Philippines? Uh, so locally, it's been 30 years. The Evo ICL has been the use for as a phakic IOL, and with continuous improvement in this design. But nowadays, we already have also two other alternatives here in the Philippines, which is the iCurl Phakic IOL and the IPCL. So both of these lenses on your right, the ICRL and the IPCL, are made of an acrylic material as compared to your EVO ICL, which is made out of polymer. Price-wise, there's also a bit of difference. And I'll show you later a comparison between the two. Uh, in St. Luke's, we've been using the EVO ICL and the iCurl Phakic IOL. We have no experience with the IPCL yet, and that's why I want to show you the comparison between the two. Um, so both of them are plate haptics, as you can see. They're very, very similar in design, and both of them sit in the sulcus. So you see the small hole here, yeah, in the center. Both of them have that, and that's the aqua port that allows the aqueous to flow so that we don't have problems with glaucoma or cataract formation. So again, the EVO ICL is made of polymer, so that's patented, and that's why you don't see any other lenses made with the same material. And that's what makes the ICL very soft and very parang pliable. On the left, you see that the iCurl is made of acrylic lens. It just means that it has less water content than the ICL, and I'll show you videos later on. You would see it's a bit stiffer compared to your ICL. So it has its pros and cons. Yeah. So very, very similar in design. I think with the naked eye, it's very hard to tell, but with the aquaport here, with the plate haptic here, you can see the leading edge. Uh, with the Evo ICL, the hole would be on your right. With the Biotech ICL, it's on your left. Refractive range wise, this is another very, very important topic with the phakic lenses. So it's the size and the range. So size wise, Evo ICL has four sizes. The Biotech ICL has a wider range of sizes. So being in an Asian country, this really matters to us because we usually tend to have smaller eyes. Refractive range wise as well, the EVO ICL ranges from a minus zero point 0.5 to a minus 18 diopter, with toricity up to 6 diopter correction, while the Biotech ICL can correct up to minus 25 diopters. So you can see that acryl, being acrylic, it's more customizable. So in our experience, we've already implanted a minus 28 diopter using acryl, and the results are excellent. So I think that's a point for acryl in this case. So I want to discuss the two crucial parts of an ICL. So it would be power and sizing. So unlike the, pseudo phakic IOL, we just measure the power, right? We just know if it's plus 21, plus 22. But with an ICL, two things are considered. It's the power and the size. So with the power, it is based on your manifest refraction. So again, unlike the pseudo
Sorry.
phakic
Saan ba
lenses,
kinala?
so that depends on biometry purely. So it doesn't matter what the refraction is that much, right? But with phakic IOLs, you have to have a good manifest because that's where the power is based from. So you have to to be confident in your refraction or a very reliable optometrist. So you also have to do biometry and keratometry, which I know you have here in Makati Med. And that's how you determine the power. Next would be a size of the lenses. So you have to determine also the size. So this is actually very crucial because you, again, place it in the sulcus. So there are a lot of problems with poor sizing, and that's where actually majority of problems comes from. It's really the sizing. So we can discuss that a bit. I just want to show you how we compute for the ICF. So if you have the Barrett 2, the different calculators. For an ICL, it's manufacturer dependent, meaning where you get the lenses, they have their own calculator. So for Evo ICL, they have the Stella. For Biotech, they have the iCurl calculator. So both of them, they need the same information. It's the refraction and the biometric value. So relatively, it's the same. Um, work up. Um, Later on, I'll show you how the calculators compare to each other on how they predict the correct size for your patient. So, why is sizing important? I keep talking about size, no? Power determines if you're on target or not, meaning if you're overcorrected or undercorrected. Volt refers more to the safety of the lenses in your eye. So, volt is actually the result of your sizing. So, this is the volt. It is a measurement of how your lenses sit in the sulcus. So, it's a space virtually, no? So, if the space is too high, you would have you would hit anterior structures like you can touch the cornea, you can have glaucoma, you can have angle closure, you can have pigment dispersion. But if it's too low, you can actually touch the lenses. So you can see it's a very, very narrow space, and there's very, very little room for mistakes or miscalculations. And that's why the vault has been long debated on how to perfectly size it. So optimally, it's around 250 to 750 microns. But again, it's not an exact number, no? So it's more of a dynamic thing. So we measure it regularly. So if you want to ask me how we size, there are a lot of ways to size the ICL. Traditionally, it's been the white to white. So that's what Stella uses, or the calculator of Evo ICL. So they just measure the white to white. As you can see, obviously, no, for the resident, how would the white to white correlate with your sulcus? It's very far off, and it's been proven already that the correlation is very poor. And that's why we have transitioned to the ASOCT or the UBM, where you can see more posteriorly, right? So the UBM, you can see the sulcus to sulcus, or where your lenses will really sit. So of course, that's what we want to measure. So with all the calculators in St. Luke's, we have settled in on the machine learning tools. So it's virtually UBM. It's still UBM, but it's a special program which helps us determine the size. So it's called the ICL Guru. So I'm showing you this because if you want to be confident in your ICL sizing, I think what's available now here in the Philippines, this would be most accurate for the ICL. So in St. Luke's, we have completely transitioned to the ICL Guru for our ICL sizing concerns. And it's very easy to use, as you can see. It gives you already the size and the predicted vault. So it will really give you confidence in implanting these cases. Yeah. So I would also want to show you the calculator showdown. So we did a study with Dr. Reginald Tan using our own patients. So just to orient you, all the blue bars are outcomes for the eye curl, and the green bars are outcomes from the ICL Guru using the ICL. The red bar is actually a publication by the group of Zaldivar. They developed the ICL Guru. So that's actually with Dr. Bobby Ang, the red bar. So let's start off with the eye krill. So what I mean by 100, 200, and 300, this is how accurately it predicts the vault, meaning if it's within 100 microns, within 200, within 300 microns. So with the ICL, you can see it has very good prediction, no? More than the ICL Guru, around 100% within 200 microns, meaning all of the cases we did, the vault was perfect, or the vault was within our prediction. Compared to the ICL Guru, so ours was around 66% within 200 microns. So in the study of Zaldivar, or the multicenter benchmark study, it's around 86.5%. So this just tells us that the iCrill has a really good calculator. So why is it so? Number one, we think that it's because it's an acrylic lens. So it's stiff. So it's really predictable because it doesn't move that much. So the vault would be relatively be the same, even if the pupil moves, even if, there are changes, as compared to the ICL, which is a very soft material. And that's why the predictions are a bit different. But to be honest, these are still good predictions, and these are the best that we have in the market today, the ICL Guru. So if you would implant an ICL, if you're starting your journey, if you really want to be confident to remove all the worries of sizing, I would suggest you do it through an ICL Guru or a UBM. So moving on, just to give you a brief background on the complications we see in phakic lenses. Number one, it would really be coming from all the vaulting problems or sizing errors. Number two would be transient elevations in IOP, but they are very manageable, especially if it's not due to the lens. It's just a normal response of the eye. So we just give them anti-glaucoma meds for a while. Cataract formation is virtually almost doesn't happen anymore just because of the new design of the lenses. So in St. Luke's, we don't see any cataract formation anymore. So endothelial cell loss, pigment dispersions are also more related to the sizing than the lenses itself. So endophthalmitis, same rates as for any intraocular surgery. So just a head-to-head long-term safety evidence. So actually both of the lenses, glaucoma, cataract, and endothelial injury-wise, they're almost the same. No significant differences, but I think the most glaring one would be the follow-up period. So Evo Vision ICL, it's been here for 10 to 15 years. That's why there's a lot of studies already available. With the biotech being here for only around 7 years, so that's the longest follow-up period. So, yeah. So, this is another study. So, the ICL has a long track record already, so we didn't anymore do a study on it. But we did a study with Dr. Reginald Tan again in St. Luke's, where we did a profile on our visual and safety outcomes with the iCrill. So you can see that visual acuity wise, it's very good, comparable with the ICL. Safety profile at 1 month, also comparable. I think only significant here would be a case of iris chafing and peripheral ASC or anterior subcapsular cataract. But there was no loss of vision or BCVA, and we just observed the patient. So this has been around at this time, maybe probably 6 or 8 months na the patient, so still doing okay. So just a brief discussion on follow-up. So if you would do a patient, how would you follow them up? So very important would be to see them right after, around 1 to 2 hours after, because the post-IOP spike would happen during that period. And we also check if the vault or the sizing of the lens is correct. If it's not, we exchange or remove it right away. So for monitoring, we do it at 1 day, 1 week, 1 month, 6, and annually. Very important here, we repeat the OCT and the UBM, and then we also do serial monitoring of the endothelium. So yeah, very easy to monitor, just like your regular cataract or your any or a patient who underwent laser refractive surgery. So nothing special, just the endothelial cell count, the pressure, and the vaulting. So I'm sure a lot of you are curious on how it affects their future cataract formation. So of course we know that cataract is inevitable. And how we do it is we do it same sitting. We explant the phakic lenses and then we do the phaco emulsification. I think the most important one is biometry wise. We have to make sure that the biometer identifies the correct anterior capsule or from the phakic IOL. So you have to check it visually on the machine if it's identifying the correct planes. If it does, you wouldn't have any problems with IOL calculation because unlike refractive procedures, it doesn't change the relationship of the anterior and posterior cornea. So You just calculate it regularly, just like how you would do in a normal patient. So I want to show you just a few videos on how we load implant these lenses, so on our actual patients. So I want to show you how we implant the ICL for those who are not yet familiar. So loading an ICL, you can see it's a very, very soft lens compared to your normal IOL. So it takes a bit of practice because usually we don't have a backup of these lenses. So it's very easy to tear, it's easy to rotate. So it takes a bit of practice, but yeah, easy naman. We do it through a pull-through technique. So that's the ICL. Uh, as compared to your acryl, so in our patients, you see this, it's a parang butterfly configuration. So yeah, so this is how it looks like. It looks like a normal IOL, no? You can already see how stiff it is compared to the ICL. So if you're a cataract surgeon, it's very familiar and very easy to manipulate yan. And then this is the injector, just like a very regular uh, IOL. So very easy. Important point here, yan. Next would be your implantation of the ICL. I'll go through this quickly. So the ICL, since it's very soft, it's a bit flimsy in the AC or in the an- anterior chamber. So we have to make sure it doesn't flip over, rotate. And that is the main difficulty with an ICL. It's because it's very flimsy. But to be honest, it's very, very forgiving, I think, on the anterior capsule and the endothelium compared to the acryl, wherein it's a bit stiffer. So it would really cause a bit more stress on your anterior capsule and endothelium if not implanted correctly. As you can see, we use a different technique here. I made sure that it doesn't touch the endothelium just because it's an acrylic lens. So, yun yung very important. Another thing is you can see the incision is a bit smaller here because with acryl, you can get away with a 2.8 millimeter. With an ICL, you have to extend the wound. So it's a 3 millimeter. But it doesn't matter that much naman. Uh, Talking of the ICL, a bit similar. I want to show you the acryl na lang. With the acryl, most people fear that it's really difficult to tuck since it's acrylic, but it's virtually the same. So nothing to worry about with that one. But you can already see with the movement now, the acryl is really a bit stiffer. So to conclude, this topic is really a primer on how or why we should use the phakic lenses in the appropriate patients. So because it really fills a critical gap for those who are very poor refractive candidates. And it's superior in terms of safety, reversibility, stability compared to its to other lenses or to RLE or PRK or other refractive lens procedures. Uh, Another advantage would be that the crystalline lens is preserved and accommodation is maintained. So right now, there are a lot of advances in the phakic lenses. We even have phakic lenses for presbyopia. So this is the Vivo ICL, Aviva ICL, and we also have that in IPCL. They also have presbyopic correcting phakic lenses. So that's an option for your patients who are presbyopic. Uh, so that ends my talk. If I can invite you, we have a new refractive suite in Laguna. So it's a bit of an hour drive from here. If you have patients for laser, like LASIK and Smile Pro, we have that already in Southern Tagalog. Thank you very much. If you have questions.
Thank you, Erika. So the ICL would be a good addition to our armamentarium as refractive surgeons. No? So we can give our patients more options. Do you have any questions for Erica?
Hi, Erica. Dr. Valerie. Question lang, are the measurements, the pre-op measurements, machine sensitive? Do you have a preferred, brand of machine? Kasi even if they get the same data, baka iba yung mga measurements nila. Or any UBM machine is okay, any anterior segment OCT is okay. Or do you have a preferred brand ba for these measurements that is quoted in the studies?
So with the pre-op measurements, sir, for biometry, um, the majority of it would be an optical biometer. So
Yeah.
we don't enter the axial length. So
Mhm.
it's really just the K values.
Okay.
So usually we would need a biometer that's dependable on the K values, or you can also use a pentacam, which is a tomographer. So that's ideal. And then for the refraction, as I said, it's very dependent on your optometrist. So that's one factor to consider. And then sizing wise, an ASOCT would just measure your angle to angle or sulcus to sulcus. So it's more of the UBM that's important. So with the UBM, what I showed earlier is the ICL Guru. So it's specific to the Sonomed Escalon UBM.
Tournament. Okay.
Yes po. And it's a additional program that you have to install.
Okay.
Yes.
Okay.
Doc Sherman, I think we have the same UBM machine with
Yeah.
St. Luke's and Asian Eye,
Yeah.
according to Pat and to Dino. So we
Yes.
just have to get the additional program if ever.
Yeah.
Yes. The
Okay.
Dr. Pat knows how.
Yeah.
There's a question from Dr. Ong Hanseng. No? Are the presbyopia correcting IOLs adaptive or do they need to be replaced over time?
So the presbyopia correcting phakic lenses from the Viva Evo ICL or the Viva line, it's like an ADOF. So really options for increasing the power of the lenses. So anyway, by that time that they would need higher correction, probably you would already do a cataract surgery wherein you can place a higher form of correction.
Wala pang toric nito.
For the, yes sir, we have toric
Meron na
options,
toric.
yes. So for both the ICL and the iCrill, we have both toric options.
Question, do you give anti-glaucoma meds right after
Routinely.
surgery, before surgery, just as a parang
Caution.
precaution for IOP spikes?
So in our practice, sir, we don't give any prophylactic anti-glaucoma meds just because we're very careful on our post-operative spike. So as long as you measure them 1 to 2 hours after the surgery, where it really matters, if they're in within normal range during that time, you should be okay for the rest of it. The next spike would happen at 3 weeks or 1 month. So during your regular follow-up, we just check them. But if you're fine with the after 2 hours, you shouldn't have any problems pa after.
I didn't see the but I know from watching sila Ellen doing ICL, you just burp the viscoelastic out, di ba?
Yun, sir. So there are several ways to do it. At St. Luke's, we're scared of post-operative spike. So
Mm.
it really depends on your technique. You can burp if you use a little bit of viscoelastic. We can do automated IA as well. So
Okay.
with St. Luke's, it's a mix. We do automated IA and that
Coaxial na
gives
IA.
us.
Yung coaxial.
Naka-ano kami, sir, eh. Yeah,
Bimanual.
coaxial.
Coaxial.
Yeah,
Okay.
coaxial. Yes, sir. We use the uh, capsule guard, the straight one. So the
Okay. And
straight capsule
yeah.
guard.
And the viscoelastic that you use is what kind of
Uh,
viscoelastic do you
we
use?
do 2% hyperproxymethyl cellulose. So it's a Orovisc or the Rumex one. is
Okay.
also very good.
Labnaw lang.
But yeah, sir, malabnaw lang. Tsaka if you can get away with a little bit, if you're an experienced surgeon, better yun kasi it will give you less IOP spike after.
And then you only clean it on top of the lens. Well, I guess, no?
Yes,
Kasi
sir.
kung ano lang yung lumabas from on top of the lens, no?
Yes,
Okay.
sir.
And
We're
then
scared of
the
the
gel actually goes out of the port,
No.
the central
The
port.
soul, the
So,
whole.
lumalabas din siya. For us, we just, flush it out. Matagal lang.
Yeah, sir.
I
Thank
think
you. Thank you.
Dr. Chodoro has a question.
So,
Yeah. Yes, it's a very practical one. I've had patients approach me and ask about presbyopia correcting, like IPCLs and ICLs, and also in the pediatric population because they know that it can be done abroad as well. I'd like to know pretty much how to approach these patients, who qualifies, who does not, what's available, and what's not in the clinic. How does one explain it? Thank you very much. And this is a great lecture, by the way. Thank you very much. And congratulations, Doc Erika.
yeah, thank you po. So for, you mean, Doc, the presbyopia correcting IOLs?
Yes.
Phakic.
And yes, Phakic. And then at the same time, we also have the pediatric population ICLs being the example in Japan, no? And some people who have been exposed to it. So how does one actually discuss it in the Philippine setting since it's not really available for a population? Thank you very much.
Okay pa, Doctor. So, for the presbyopia correcting phakic lenses, Doctor. So right now, the one from Transmedic or the Evo Viva ICL is not yet available. But Dr. Bobby Ang has already extensive, what do you call this? Extensive experience on it since he did a study. But it's not yet available locally. So we're waiting for that. For the IPCL, to be honest, Doctor, we don't have any experience personally at St. Luke's, since it's a certain group that does it at ICANN. So if interested on that, Doctor, I think it would be best to ask them about it, since we don't have any experience yet. For patients who are presbyopic, what we do at St. Luke's is we do monovision, or we could monovision, so with the ICL, which is also a very good option as long as patient can tolerate the anisometropia. But we don't go above a 1.5 diopter difference uh, to preserve stereo acuity. And then because we also have Press Beyond there, so we also offer that for patients. Aside from that, for the pediatric phakic lenses, we don't have it here yet in the Philippines. I don't hear any discussion on it, or maybe I'm not yet familiar. But I think the main problem for that would be the sizing, because if pediatric, the size would really be different. I'm not sure of the technology, Doctor. I haven't
Yes,
attended
yes.
anything. Mhm.
Thank you very much
You're
clarifying that. That's very helpful. Thank you, Dr. Erika.
Thank you pa, Doctor.
Sorry, Erica, what's the longest na implanted in St. Luke's na
History.
experience nyo?
Longest, Doc.
For the acryl.
Longest experience, Doc. I think
Ah.
by this, we did it. The first one was last April. So it's been a year.
Okay.
It's been 1 year, Doc. I think it's, yeah, 1 year. Si Doctor, I think in Peregrine, si Doc Harvey Oy has also extensive experience with the acryl. Yeah.
Erika, how do you explain to patients the difference between the Evo ICL and the iCrill? Like when
Uh,
you,
Offer.
when you talk to them, no?
Yes, Doc. So, of course, we all know that phakic lenses are a bit expensive. So, we actually explain first the need for a phakic lens, and then afterwards, we discuss both options, with emphasis on the material, like study or what's known about it long term wise. Um, Also, we of course disclose where it's manufactured kasi the ICL is from the US and the ICRL is from India. So that's another factor for most patients. But one crucial factor would also be the price. So with the
Yeah.
ICL right now, for information, I think it's around 55,000 for the toric lenses. And then for the ICRL, it's a bit cheaper. So I think the non-toric one is 25,000 per piece. And then the toric one is 35,000. So it's also a big factor for most patients. Yes. So other patients, we really don't give them an option to not do the phakic lenses. They just choose between the two. And yun, you would be surprised. A lot of them are willing to actually do pa din the acryl phakic lenses, even if it has a shorter follow-up in the manufacturer. But yeah, we discuss both options for transparency po.
Di ko alam kung pwedeng tanungin, how much do you add to the price of the lens? Para lang we have an idea, di ba?
For
Like,
the lens, we actually package it po eh. So, given the, usually doc, paano ba to? Kino-compute ko. Usually doc siguro times two, around times two. Kasi, but usually package na doc yung ano eh, yung
so parang
eye cream.
ballpark
Mm.
figure comparing the price of uh,
So with the
ICL and ano.
iCurl, it's around, with the iCurl doc, probably it's around 180 to 190, both eyes na. With the iCurl, it's around, with the ICL, it's around 120 per eye. So medyo malaki yung difference.
Okay. Okay.
Yeah, ganun doc. Yeah.
And then you really file PhilHealth ba?
Yes, doc. We filed PhilHealth for the parang secondary intraocular insertion.
Tapos one eye at a time?
So doc, kami sa St. Luke's, we do it both eyes at the same time. May mix eh.
But
Others do it one eye at a time kasi daw yung PhilHealth, it will cover more if it's one eye at a time. So if you're open to that, I think it will cover more for the cost ng patient. But for most sa amin sa St. Luke's, we do it both eyes at the same time kasi we're, a bit wary of the
yeah.
anismia.
Oo nga. Tapos you file just for one eye?
Yes, doc.
Or
We
may
just,
half, one eye lang, di ba?
wala daw eh. One lang pwede. One
One
eye
eye,
lang.
yeah. Okay.
Dr. Dino has a question.
Yeah, a personal question na for Erika. What's your personal cutoff for
For myopic.
ano?
Ngayon. Right now, it's -5 and above for phakic lenses.
Pero, medyo,
Low.
medyo lower yung konti, 400.
I think the lowest I did was a -3. Yeah, just because of borderline corneas. But for those cases, usually discuss ICL late. I mean later, lalo na if they're good candidates. Just because of course it's still an intraocular procedure, a lot of patients are still scared about it. But dun sa we attended the latest ICL users meeting in China, Korea, it's their first go-to already. They're really shying away from lasers right now, even smile or even lenticle extraction. -3 is majority of their cases. They're different. They're richer, I guess.
There's another question from Neil. Do you have any experience with phakic IOLs in uveitis patients?
Not yet po. Usually, if patient has history of uveitis, we already eliminate those cases already. Because there's really a lot of you would be confused with the chafing of the lenses, which really happens in phakic lenses, IOP elevation. So I guess it would really be different po, if we do it in a uveitic patient.
Sometimes, di ba, parang right after post-op, you see iris pigments on the lens, and then they eventually go away over time. Same rin ba for acryl?
Yes, doc. With acrylic, it's the same. You also see those pigments, if not a bit more. I guess kasi acrylic siya. So every time the iris passes through it, it causes a bit more chafing, I guess. So just a tip for acryl po, no. So even if they say it's the same vault, I mean yung shape ng lens, it's the same. But in our experience, more gel gets trapped under that optic kasi hindi siya nag-flat eh. It's really stiff. So with that, you would have to do a more extensive removal of the gel kasi it gets trapped more. Even if you do the same thing like an IA, everything, I would take extra time to really get that gel out of that space. Mm.
Dr. King, ask a question.
Hi, congratulations. It's a very interesting talk. I have a question about, I don't know if I missed it earlier. Do you have a cutoff for implanting ICL for those who might develop cataracts? And what is the incidence of cataract formation among patients undergoing or who've had phakic IOL?
Yes, doc. So with age-wise, for those with cataracts already, we definitely don't do it. But for those who are 40 and above, we still do phakic lenses as long as they don't have cataracts po. So we do a bit of mini monovision for them and they're very happy. So that's an option for your presbyopia patients. But as long as there's any sign of cataract, we don't do it anymore. So second, incidence of cataract, in the papers with the ICL specifically, it's less than almost 0.1%. It's very, very low, just because of the new design of the Evo ICL. So there's already an aqua port in the middle. There's a hole in the middle. So that actually lets the aqueous circulate and it prevents any touch on the anterior capsule. So now we only see the anterior subcapsular opacities if there's a traumatic delivery of the phakic lenses. If it's a traumatic, almost none po, even if the volt is very low, like 100, 120. So we haven't seen it any cataracts. Unless, of course, the acryl is a different story po. Because, yun nga, as I showed you, we had one case of anterior subcapsular opacity with the acryl. Yep. But it didn't change any vision wise. So the BCVA is still the same. The UCVA is still the same. Yun.
How old is your oldest ICL patient? Phakic
Oldest
lens patient.
ICL, 48 po, Doctor. 48. We did 1.5 monovision. Very, very happy.
Sherman, you have a question?
Yeah. Have you had to explant? Not for cataract, but explant because of whatever reason. ICL or the acryl. Have you had to do it?
So with the acryl, we haven't had to explant uh, any lenses yet. With the ICL, in the past, maybe 2 to 3 years, none yet. Um, and especially the past year when we started the ICL Guru, we haven't had to do any exchanges or explants. And mostly these are usually from the sizing problems or yung mga ina-explant. Usually pag high volt. But with the ICL Guru, we haven't had any yet. Because nga, the sizing is usually great or good.
Okay. Thank you very much.
Any other contraindicated patient conditions? What about diabetics or GLAU?
Yes, so sorry, I didn't wasn't able to mention, but usually we would need a healthy eye. So meaning no other comorbidities with the eye, such as diabetes, uveitis, any glaucoma, any cataracts. Just because these patients would be a bit harder to follow. Even Fuchs are problems with the endothelium, we don't implant anymore. So that's a main contraindication. The only thing I think we allow in phakic lenses would be dry eyes. Yeah.
Yeah, because they don't have dry eye after, diba? They don't
Yeah.
complain of dry eye.
Yes.
Do you have any other questions?
That's fine. Dr. Aminsi, Doctor.
Thank you for the lecture. Very interesting. Cases of Marfan's. Diba?
Oo.
Yeah, so cornea is medyo unstable.
Yeah.
Laser and their eye myopia and zone of instability.
Yeah.
Have you
Experience though.
experienced?
We haven't had any experience with those, but if I think about it, I wouldn't implant one, just because the ICL will sit heavily, yes, doc, on the sulcus, on the zonules, and when we implant them, it's technically blind procedure when we implant the plate. So, yes, doc. So sometimes, actually, parang 60 to 70% of our cases, it actually sits on the ciliary body and not actually on the sulcus. So, meaning that's closer to your zonules, right? So, any movement of the ciliary body that might really affect the zonules of Marfa.
Stories about some instability after many years of ICL.
But so far, none yet, doc. Yeah. Okay, doc. With our experience, none yet. Po.
Okay. So if we don't have any other questions, thank you so much, Erika, for that
Lot of
wonderful
fun.
lecture. And hopefully we start implanting ICLs in Makati Med.
Yes.
Thank you very much, Erica. Thank you very much, Ellen. And thank you very much, everyone, for attending this Friday's conference. No, again, say a little prayer for our examinees for next week. Two of them will be taking the oral exams. And I'd like to thank everyone for attending today, and I'd thank our speaker, no, for a very wonderful lecture. So, good evening, everyone, and have a great weekend. Thank you very much.